of the most important factors which increases the cardiovascular mortality and morbidity. If hypertension is not controlled for a long period of time, it can damage the heart, blood vessels, and kidneys, which can lead into angina, congestive heart failure, okay, renal failure. So it is very necessary to control the blood pressure. So by definition, hypertension, a systolic BP of more than 140 and a systolic BP of more than 90 is considered as hypertension. So according to the American Heart Association classification, say they have given the range for the diagnosis of hypertension. Okay, so that is normal is less than 120 by 80. We all know that pre-hypertensive group will between the 120 to 139, that is systolic, and 80 to 89 diastolic. Stage 1 hypertension. This is the where we have to start the treatment. That is about 140 to 159 millimeter of mercury systolic. Diastolic will be 90 to 99. Stage 2 will be more than 160. Hypertensive crisis, we call it as more than 180, and the diastolic more than 110. So what are the types of hypertension? There are two types: essential or primary hypertension or secondary hypertension. Most of the almost 90% of the cases of hypertension fall into essential or primary hypertension, where the cause is not known. There is no particular cause for the hypertension that falls into essential or primary hypertension. Why is called essential? It has been thought that, see, the elevated BP is necessary for the maintain the adequate tissue perfusion. That's why it is called as essential hypertension. Where most of 90% of the cases fall into this category. There is no exact uh, mechanism or the cause is not known. We call it as etiology is unknown. Secondary hypertension may be due to the underlying disorders like hyperadrenergic states like pheochromocytoma, primary hyperaldosteronism, Cushing syndrome, or coarctation of aorta. In these conditions, the secondary hypertension, the underlying cause has to be corrected to bring the BP to normal level. What are the other factors which contribute to hypertension, like stress, increased sodium intake, obesity, smoking, alcohol? These are all the risk factors for the development of hypertension. Now we'll know what are the regulatory mechanism which is involved in the hypertension. I want you to concentrate only the, so don't concentrate whatever there in the red box, okay? Just concentrate. So whenever there is a fall in blood pressure, okay, when there's fall in blood pressure, it is sensed by the Borer receptors located in the carotid sinus as well as aortic arch, which stimulates the vasomotor center in the brain stem. As a result of which, there will be increased sympathetic activity. There will be sympathetic discharge, which act, that is the release of adrenaline, noradrenaline takes place, which acts on the beta-1 receptors of the heart. So we all know what is the action of beta-1 receptor of the heart. It increases the heart rate and increases the cardiac output. Ultimately, it leads to the increased pressure. At the same time, the increased sympathetic discharge, the neurotransmitters acts on the alpha-1 receptors of the blood vessels, which increases the peripheral resistance in the blood vessels, which again contribute to increased BP. Okay. At the same time, whenever this sympathetic increased sympathetic activity, it also activates the beta-1 receptors, which is located in the juxtaglobular cells of the kidney, and also the reduced blood pressure, which is sensed by the afferent renal arterioles, which gives a signal to macula densa to release the renin. So activation of beta-1 receptors at the juxtaglobular cells, and also the release of renin, which is signal is given by the macula densa, which causes the increased renin activity, okay, and in terms produces the increased angiotensin 2. We know angiotensin 2 is a potent vasoconstrictor, which acts on the arteries, blood vessels, which increases the peripheral vascular resistance, and again which contribute to hypertension, elevated BP. At the same time, the angiotensin 2 also causes the release of aldosterone. We know for the function of aldosterone is to cause the sodium and water retention. The sodium and water retention causes the increased blood volume. Increased blood volume ultimately leads to increased cardiac output. The long-term basis, it also leads to increase in blood pressure. So you have to remember, any factors which leads to increased cardiac contractility, which increases the heart rate, which increases the cardiac output, ultimately you rise to increased BP. Okay, any factor which causes the increased blood volume, which also contribute to increase in cardiac output and BP, and with increased peripheral vascular resistance, which also contribute to blood pressures. If you know this mechanism, by looking at the diagram, this regulatory mechanism itself, we can classify, remember the drugs which can target at particular sites, which is useful in the treatment of hypertension. Okay, we'll come to that. What are the classes of drug? Here only we can see. So the beta blockers, which blocks the sympathetic activity. Okay, so you have to reduce the peripheral resistance in the arteries. You have to use the alpha blockers as well as vasodilators. Okay, if you want to inhibit the renin-angiotensin activity, you have to use the ACEI inhibitors, ARBs. Okay, you can directly inhibit the renin inhibitors. Okay, if you want to inhibit the aldosterone, you can use the aldosterone receptor antagonist. Okay, if you want to reduce the blood volume, you can use the diuretics. Okay, if you want to decrease the peripheral vascular resistance, you can use the arterial dilators. So by this mechanism, we can reduce the BP. So one more very important you have to remember to understand the antihypertensive drugs and the mechanism of antihypertensive drugs. Always remember, blood pressure is always the product of cardiac output and the systemic vascular resistance, or otherwise called as peripheral vascular resistance. That means any factors which leads to increased cardiac output leads to increased BP. Any factors which increase the peripheral vascular resistance, which causes it leads to increase in BP. What does it mean? That means to say that if you decrease either cardiac output or you decrease the peripheral vascular resistance, you can bring down the blood pressure, you can control the BP, you can reduce the BP. So most of the antihypertensive drugs are targeted towards reducing the cardiac output as well as reducing the peripheral vascular resistance. So remember these two terminologies, cardiac output and peripheral vascular resistance, because most of the drugs which is targeted to reduce the BP act by reducing the cardiac output. One or the other way acts by reducing the cardiac output and decreasing the peripheral vascular resistance. Very important from blood pressure is the product of cardiac output as well and peripheral vascular resistance. So this is the classification of antihypertensive drugs, which I discussed along with that autoregulatory mechanism. Okay, so the drugs like beta blockers, ACE inhibitors, angiotensin receptor antagonists, okay, alpha blockers. Okay, these are the diuretics. So these drugs we have discussed in detail in previous classes. However, the important points relevant to the use these drugs in the hypertension will be discussed here along with some important points. So today's class will concentrate mostly on the calcium channel blockers, vasodilators, okay, and other drugs will follow. Okay, first we'll discuss the calcium channel blockers. Before going to the direct calcium channel blockers, I want you to know what are the types of calcium channel. Okay, these are the voltage sensitive calcium channels or voltage regulated calcium channels are divided into three types or four types, like L type, T type, neuronal type. Okay, these are the later addition. Okay, mainly the three types L, T, and N. L stands for long lasting, T for transient, and neuronal. So the activation threshold for L type of calcium channels high, inactivation threshold is slow, the rate of inactivation is slow. What are the location of this L type of calcium channels? It is mainly located in the cardiac smooth muscle of the blood vessels, SA node and AV node. What is the function in the cardiac muscle? It increases the contraction coupling, increases the contractility. In the smooth muscle of the blood vessels, it causes contraction of the blood vessels. Okay, in SA node, it regulates the pacemaker activity. In the AV node, it increases the conduction velocity. Okay, there are T-type calcium channel located mainly in the SA node and mainly in the neurons. Okay, the T type of calcium channels which is located in the neuron, which is responsible for the like repetitive thalamic spikes which is created that causes seizures. Okay, that is the drug of choice. Like that is the target of action of the drug like ethosuximide in treatment of absence seizures. So the overactivity of T type of calcium hypothalamus. Okay, so by targeting that T type of calcium channels mainly by the ethoxamase, that is drug of choice in the absent tissues. Okay, other like N type calcium channels mainly located in the neurons mainly acts as the release of neurotransmitters takes place with the help of this. So I want you to consider like calcium channel blockers mainly they target the L type of calcium channels. Very mainly target the L type calcium channel. Okay, we'll see the mechanism of action of calcium channel blockers. Before going into that, what normally happens in the blood vessels, smooth muscle of the blood vessels. Okay, this is the diagram which shows this is the vascular smooth muscles. Inside the smooth muscle, what happens? The resting membrane potential of this vascular smooth muscles is minus 40 millivolts. Okay, and these calcium channels, this L-type calcium channels, which is located here, okay, they are highly activated when the membrane in depolarized state. That is around minus 40 millivolts. Okay, it is highly active. Calcium channels are highly active or opens when the membrane polarization reaches minus 40 millivolts or during the depolarization. What happens? There will be entry of calcium to this L-type of calcium channel. This entry of calcium inside the vascular smooth muscle causes this release of the calcium which is stored intracellularly. So that the calcium concentration inside the vascular smooth muscle increases, which combines with the calmodulin. Okay, this complex activates the myosin light chain kinase, called as phosphorylation or nothing but the activation of myosin light chain kinase. This myosin light chain kinase, when it is activated, interacts with the actin, which causes contraction excitation coupling that leads to the contraction of vascular smooth muscle. So whenever the contraction increases, the peripheral vascular resistance of the vascular smooth muscle increases. Okay, that is the normal. And this L type of calcium channels exist in three states. One is in the resting state, another in the activated state, and in the inactivated state. So our calcium channel blockers mainly binds to activated as well as inactivated state and prevents the entry of calcium inside the vascular smooth muscle. Whenever there is no entry of calcium channels inside the vascular smooth muscles, there is no release of calcium from the intracellular store. There is no interaction with calmodulin. There is no activation of myosin light chain kinase and myosin light chain. There is no interaction with the actin. Okay, there is no contraction of vascular smooth muscle. That means the vascular smooth muscle will go into state of relaxation, which leads to decrease in peripheral vascular resistance. Okay, ultimately we know blood pressure is the product of cardiac output and peripheral vascular resistance. So by inhibiting the entry of calcium inside the vascular smooth muscles, calcium channel blockers reduces the peripheral vascular resistance. Okay, so these calcium channel blockers also acts on the cardiac muscles. That is a different mechanism. We'll discuss in detail when we uh, discuss the angina treatment of angina, drugs treatment of angina. We will now concentrate towards the treatment of hypertension. So this is the classification of calcium channel blockers. Mainly is classified into dihydropyridines and these are the non-dihydropyridines. So dihydropyridines are highly potent drugs, okay, and they are lipophilic. Okay, whereas these non-dihydropyridines, the verapamil and diltiazem, okay, they are hydrophilic and less potent. And one more point I wanted to remember, this verapamil and diltiazem are more of cardioselective. Okay, they also acts on the calcium channels of vascular smooth muscles, but they are more selective towards the heart. Whereas dihydropyridines are more vasoselective. Okay, they also acts on the calcium channels of cardiac muscles, but their dihydropyridines are more of towards the vascular smooth muscles, whereas non-dihydropyridines, verapamil and diltiazem are more of cardioselective. Okay, some important features of each drug you need to remember here is like nimodipine. Okay, nimodipine is highly lipophilic and has got higher affinity for vascular smooth like blood vessels of the brain, cerebral blood vessels. So it is mainly used in the treatment of or the control of blood pressure in the subarachnoid hemorrhage. Okay, cilnidipine, it has got renoprotective action. That means it reduces the proteinuria, so thereby it has got renoprotective effect in patient with hypertension. Okay, lasodipine is the longer acting drug which can be used once daily. Then nitrendipine is one of the drugs that causes increased nitric oxide release from the vascular endothelium by inhibiting the phosphodiesterase enzyme. Okay, amlodipine is a longer acting drug. Okay, and most commonly used antihypertensive. Okay, verapamil and the diltiazem, they are most towards the cardioselective. We'll discuss in detail what are the use of these drugs. So what are the adverse effects? Mainly these drugs produces ankle edema. Why ankle edema? See, these calcium channel blockers, whenever you give it, causes dilatation. This is the pre-capillary vessels. Okay, this is the post-capillary. The blue is the post-capillary, these are the pre-capillary. Whenever you give the calcium channel blockers, it causes dilatation of the pre-capillary vessels and the relaxation of the or constriction of post-capillary vessels. As a result of which, the hydrostatic pressure inside the vessels increases, which pushes the fluid out. That is the reason responsible for the development of ankle edema is seen with most of the calcium channel blockers. Okay. So, whichever the drug which causes dilatation of the vascular smooth muscles by reducing the vascular peripheral vascular resistance, ultimately that produces headache, flushing, palpitation. These are the very common adverse effects seen with the any drugs which causes vasodilation of the blood vessels that ultimately causes headache, flushing, palpitations. Okay. Other side effects like drowsiness, voiding difficulty because of relaxation of the bladder, so that produces voiding difficulty in the tissues. And also worsening of the GERD, gastroesophageal reflux disease, because it causes relaxation of the lower esophageal sphincter, so there will be reflex of the gastric contents happens inside the esophagus, leads to worsening of GERD. So now we'll see what are the status as antihypertensive. Mechanism of action we learned, it decreases the peripheral vascular resistance and the blood vessels, and also it has got negative inotropic and chronotropic action on the heart. It reduces the cardiac contractility, decreases the heart rate, cardiac output is slightly reduced. So as a result of which the BP will come up. So it reduces both the product of blood pressure, that is the cardiac output, as well as peripheral vascular resistance. So these dietropyridines, because they reduces the blood pressure, so there will be reflex tachycardia. There will be a compensatory mechanism. There will be stimulation of the sympathetic nervous system, which produces reflex tachycardia. Okay, this reflex tachycardia is less in case of the non-dietropyridines because it has got more cardioselective that inhibits the calcium channels in the cardiac muscle. So that reflex tachycardia is less in the non-dietropyridines like verapamil and diltiazem, whereas reflex tachycardia is more in the dihydropyridines group of drugs because of rapid reduction in the blood pressure as well as a compensatory mechanism, the stimulation of sympathetic nervous system, which increases the adrenergic drive to the heart, increases the heart rate, that leads to tachycardia, which is not seen with verapamil and diltiazem because they are more towards the cardioselective, which decreases the calcium channel in the inhibits the calcium channel in the cardiac muscle. So these calcium channel blockers now used as a monotherapy, particularly in the elderly patient. Okay, it is a safer hypertensive, can be used in the patient with asthma, angina, diabetes, and the peripheral vascular disease. Okay, it is the safer antihypertensive in pregnancy. So one more point you have to remember, it should not be used along with beta. The combination of calcium channel blockers and the beta blockers should be avoided because both have got negative inotropic action on the heart. Okay, it causes additive sinus depression. Okay, which leads to AV block. Okay, both the drugs has got negative inotropic action on the heart, so which adds together results in the bradycardia, sinus depression, ultimately leads to AV block. So it has to be avoided. That means it comes partial heart block into complete heart block in patient with the cardiovascular factors. So remember, beta blocker should never be combined with the calcium channel blocker, especially verapamil and the diltiazem, because they are cardioselective calcium channel blockers. Next group of drug is central sympatholytics. The most important drug is clonidine. It belongs to immunoglobulin group. Okay, what is the mechanism? Anti-hypertensive mechanism of action. Okay, how it reduces the BP. So clonidine has got agonistic activity of alpha 2 receptor, basically alpha 2A. These alpha 2A receptors are mainly located in the vasomotor center in the brain. Okay, it is located postsynaptically. Whenever these receptors are stimulated, it decreases the central sympathetic outflow, decreases the release of adrenergic neurotransmitters. Okay, whenever we stimulate the alpha 2A receptors, one point you have to remember, alpha 2A receptor, whether it is located presynaptically or postsynaptically in central nervous system, inhibits the release of neurotransmitter, decreases the central sympathetic outflow. Whereas the scenario is different when it's located in the periphery. Okay, whenever the periphery, alpha 2 receptors causes vasoconstriction. Okay, but whereas in the central nervous system, it is located alpha 2A receptors located in the postsynaptically. Whenever you stimulate these receptors, it decreases the central sympathetic flow. So whenever the central sympathetic flow is decreased, there's a decreased sympathetic activity. The adrenergic drive towards the heart as well as blood vessel decreases, which results in decreased heart rate, leads to decreased cardiac output. Okay, ultimately the BP will come. So it also got the presynaptic alpha 2 receptors. It has got inhibitory action on the, it activates the presynaptic inhibitory alpha 2 receptors. See, that's what I told. This is the presynaptic alpha 2 receptors. This is the target organ. Okay. So this is the target organ. This is the presynaptic alpha 2 receptors. These are got the autoreceptors. If you remember, we discussed in the autonomic nervous system. So the alpha 2 receptors located in the presynaptically, we call it as autoreceptors. That means whenever you stimulate these receptors, it inhibits the release of neurotransmitters like adrenaline, noradrenaline is decreased. Activation of these receptors decreases the release of neurotransmitters, adrenergic neurotransmitters. So whenever there is no adrenergic neurotransmitters, it cannot act on the heart as well as blood vessels, thereby and the blood vessels it decreases the peripheral vascular resistance, ultimately contributes to decreased BP, and heart there is no adrenergic drive on the heart, there is no tachycardia, or there is no increased cardiac contractility, there is no cardiac, the cardiac output comes down as well as the BP will come down. Okay, this is how the clonidine reduces the blood pressure. And also they say that recently it also activates the imidazoline type of receptor I1. Okay, it belongs to imidazoline, activates the imidazoline receptor I1, which controls alpha 2 receptors. Okay, that is one more point you have to remember related to clonidine. So obviously it is a treatment of hypertension. We discussed how it reduces BP. So what are the other uses of this clonidine? It's used to control the diarrhea in patients with autonomic neuropathy. Okay, the alpha it causes alpha 2 receptor mediated sodium retention, so that produces a beneficial effect in the treatment of diarrhea in patients with autonomic neuropathy. Okay, in nicotine, alcohol, and opioid withdrawal, so there will be increased sympathetic activity. Okay, so the symptoms of increased sympathetic activity will be seen in the withdrawal of nicotine, alcohol, and opioids. To inhibit that, the symptoms of increased sympathetic activity, we know it reduces the central sympathetic outflow. So that can be utilized in the treatment of withdrawal symptoms, which is due to the increased sympathetic activity. As well as menopausal heart flashes, it also due to the increased sympathetic activity, which can be decreased by giving the clonidine. Okay, these are the other uses. So when you use clonidine for a long-term basis and you suddenly withdraw the drug, so there will be a rebound hypertension because there will be increased release of then catecholamines takes place after a long period of time. So there will be continuous inhibition of the neurotransmitter takes place with the help of clonidine treatment. Whenever you stop the drug immediately, there will be release of large amount of the catecholamines as well as the receptors are hypersensitive, which causes rebound hypertension. Okay, other side effects like sedation, dry mouth, these are the other side effects. Okay, the clonidine also causes postural hypotension, but it is asymptomatic. Okay, that's not that bothering to the patient. Methyl dopa, this is one more drug. Okay, this methyl dopa, whenever you give, it is converted into alpha methyl dopamine with the help of aromatic dopa decarboxylase enzyme, and it is converted into alpha methyl noradrenaline with the help of beta hydroxylase enzyme. This alpha methyl noradrenaline is stores gets in the vesicles in the adrenergic neuron. So it is released as a false neurotransmitter. Okay, it is released as a false neurotransmitter. Methyl dopa is converted into alpha methyl noradrenaline and stored in the vesicles in the adrenergic neuron. When it is released, it acts on the alpha 2 receptors in the brain. So we know whenever it activates the alpha 2 receptors in the brain, it decreases the sympathetic outflow. So whenever the sympathetic outflow decreases, the adrenergic drive to the heart as well as blood vessel decreases, and the heart decreases the cardiac output, decreases the BP, and the blood vessels it decreases the total peripheral resistance, ultimately leads to decreasing BP. Okay, this is the antihypertensive mechanism of methyl dopa. The adverse effect, it causes production of autoantibodies against the Rh antigen located on the erythrocyte, and over a period of time, in 5% of the patient, it can produce hemolytic anemia. So that's why you get the positive Coombs test. Other side effects like sedation and lethargy. One more point you have to remember: this clonidine and methyl dopa they causes fluid retention and edema. So it is preferable to combine these drugs with the diuretic, which compensates the edema. If you combine the diuretics, which will take care of the fluid retention and the edema, which is caused by the clonidine and beta-dopa. Okay, it is the antihypertensive drug of choice in pregnancy. It is safer in pregnancy. There's no deleterious effect on the mother and fetus, so it can be safely given in pregnancy. Vasodilators. So the drugs like hydralazine, diazoxide, and phenol. These are preferential arterial dilators. Okay, there is no effect on the vein. Or potential arterial dilators. What is the mechanism of antihypertensive action? So it decreases the AP3-induced calcium release in the vascular smooth muscle. We now have learned that whenever the calcium is not there in the vascular smooth muscles, the contraction will not take place. If there is no contraction of vascular smooth muscles, the total peripheral resistance comes down, which leads to decrease. And most important mechanism of action, they activate the potassium channels. We know, see, this is the vascular smooth muscle. Okay, this is the potassium channel. Whenever the potassium channel opens, so potassium goes out of cell, the membrane becomes negative because potassium carries the positive charge. Maybe it is intracellular ion. Okay, whenever the potassium channel opens, the intracellular potassium, when it goes out, we are losing the positive ion from inside the cell. The cell membrane potential becomes negative. We know whenever the membrane potential is negative, we call it as hyperpolarization. Okay, hyperpolarization is nothing but a state of relaxation inside the blood vessels, which decreases the total peripheral resistance, ultimately contributing to decreased in BP. This is the major mechanism action of this arterial dilators, activation of potassium channel by causing the hyperpolarization, relaxation of the blood vessels, ultimately leads to decreased total peripheral resistance and decreased BP. So there little bit effect on the release of nitric oxide has also been produced, which also increases the cyclic GMP inside the vascular smooth muscles that contribute to vasodilatation. Okay, this hydrolysis, okay, diazoxide has also the same effect as that of hydrolysis. And one more important is the diazoxide produces hyperglycemia. That's one important point. Hyperglycemia and hyperuricemia. Hyperglycemia and hyperuricemia is produced by diazoxide. Okay, and a diazoxide mainly used in the treatment of insulin. Okay, because there will be increased production of insulin that produces hypoglycemia. So since it has got hyperuricemia, because it decreases the release of insulin from the beta cell of the pancreas by activating the potassium channels in the beta cells. So there will be decreased release in insulin release that is used in the treatment of insulinoma, and it produces hyperglycemia and hyperuricemia. This is diazoxide. The phenoldopa, it is a dopamine D1 receptors agonist, which causes dilatation of peripheral arteries and natriuresis, which leads to decrease in blood pressure. Okay, status as antihypertensive, it is the used in the pre-eclampsia. This is used in the hypertension in pregnancy. This is the safer drug in the hypertension in pregnancy. We call it as pre-eclampsia. So mainly this drug is used whenever the first line drugs fails to decrease the BP to target levels. Okay, it is used as an added drug along with the other groups. So when the first line drugs fails to reduce the BP to target levels, these vasodilators are added. Okay, so other uses, it can be used in treatment of hypertensive emergency, basically hydrolysis. So these are the vasodilators I told. Whenever the drugs which are the vasodilators, what are the side effects? It produces facial flushing, mandatory injection, throbbing headache. Okay, other side effects like lupus erythematosus, rheumatoid arthritis like syndrome. These are some of the side effects of the vasodilators. Minoxidil. Minoxidil is one of the most preferred vasodilator drug. Okay, it is not used as a antihypertensive. So the mechanism of action is it opens the ATP sensitive potassium channel. We know whenever the potassium channel opens, there will be hyperpolarization of the vascular smooth muscles, which leads to relaxation, which reduces the total peripheral resistance, leads to decreased BP. That is the antihypertensive mechanism of minoxidil. Okay, one of the most important side effects of this minoxidil is hirsutism. Okay, that is utilized in the treatment of male pattern baldness and alopecia areata. How does it causes increased hair growth? Is it by opening the potassium channels, it increases the microcirculation around the hair follicles, and also by direct stimulation of the resting hair follicles, it promotes the hair growth, which can be utilized in treatment of male pattern baldness and alopecia areata. Sodium nitroxide. Sodium nitroxide, the previous vasodilators what we discussed, they are preferentially arterial vasodilators. So this is the sodium nitroprusside, which acts both on the arteries as well as veins. Okay, it dilates both the arteries and veins. How? It releases the nitroprusside, releases the nitric oxide. This nitric oxide enters the vascular endothelium. It increases the cyclic GMP. Okay, whenever the cyclic GMP increases, it causes dephosphorylation of myosin light chain kinase. So it inhibits the activation of myosin light chain kinase, thereby inhibits the contraction coupling with actin. So there is no contraction of vascular smooth muscles. The total peripheral resistance comes down, leads to decrease in BP. Okay, I'll show you the diagram. Okay, this is the diagram. See, sodium nitroprusside releases the nitric oxide. Okay, it increases the concentration of CGMP. So CGMP, it causes dephosphorylation of myosin light chain kinase. Activation of myosin light chain kinase will not take place whenever the CGMP increases in the vascular smooth muscles. Okay, at the same time, it also inhibits the opening of calcium channel, inhibits the entry of calcium inside the vascular smooth muscles. Together, they inhibit the contraction of vascular smooth muscles. The undergo a state of relaxation, the total peripheral resistance comes down, the BP comes down. Remember, it dilates both the arteries and veins. Okay, so whenever we use sodium nitroprusside, it splits into cyanide by inside the RBCs. The cyanide undergo further metabolism in the liver, produces thiocyanate. Okay, the metabolism of thiocyanate is slow or it stays in the body for more than 3 days. That causes lactic acidosis as well as psychosis. Okay, that is the side effect of nitroprusside. That's why it should not be used in pregnancy. It produces this cyanide toxicity in mother as well as in the fetus, should be avoided in hypertension in pregnancy. And one more important point, this sodium nitroprusside decomposes at alkaline pH as well as when you expose the drug to sunlight. So that's why the infusion bottle should be always covered in the black paper. Whenever you start the infusion bottle should be covered with black paper because it decomposes at alkaline pH as well as exposure to sunlight. Okay, it is used as a second line drug in the hypertensive emergencies. Alpha plus beta adrenergic antagonist. The two important drugs is labetalol and carvedilol. Labetalol blocks both beta 1 plus alpha 1, blocks both beta 1 and alpha 1. It has got intrinsic agonistic activity at beta 2. Okay, so on blood vessels, by blocking the alpha 1, it decreases the total peripheral resistance as well as decreases the pressures. Mainly, this labetalol is used in the hyperadrenergic states in pheochromocytoma, which is reaction clonidine withdrawal, because these are the hyperadrenergic state. There will be increased blood pressure. Otherwise, we call it hypertensive crisis. To reduce that hypertensive crisis, we use the following conditions. Okay, it is also one of the safest antihypertensive used in the pregnancy. Carvedilol. These are the another drug. So it also blocks more beta 1 and beta 2 and less of alpha 1. Okay, also they reduces the total peripheral resistance. It has got additional property. It has got antioxidants property. It inhibits the free radicals mediated damage, and also it inhibits the vascular smooth muscle mitogenesis, which produces beneficial effect in the treatment of patients, hypertensive patient with congestive heart failure. Carvedilol, very important. Alpha blockers. Alpha blockers mainly redoxin, teroxin, and doxycycline, mainly alpha 1 selective. Okay, alpha 1 selective, mainly located in the blood vessels. Okay, it dilate by blocking the alpha 1 receptors. We know whenever stimulate the alpha 1 receptor, it produces vasoconstriction. So when you are blocking this, it produces vasodilatation both in the arteries and veins. Okay, so by causing vasodilatation, by blocking the alpha 1 receptors, so it produces vasodilatation, leads to decreased TPR, leads to decreased blood pressure. Okay, the first dose effect, the postural hypertension and syncope are the most common side effect of alpha blockers, because there will be venodilatation. I told dilatation of vein. See, venodilatation. Whenever the drug which causes dilatation of veins, the postural hypertension is common. So it can be avoided by giving the drugs in the night. Okay. So and during the bedtime, it can and starting the low dose as well as giving this drug in the bedtime, we can avoid the postural hypertension. Okay, not used as a first line drug, so it can be used along with the diuretics or beta blockers. So very important. Now we come to the beta blockers. So beta blockers we have discussed in detail in previous classes. Now with respect to antihypertensive action, we'll discuss. So how beta blockers reduces BP? These are the following mechanism by which it reduces BP. By blocking the beta 1 receptors in the heart, it decreases the heart rate, induction velocity, myocardial contractility, cardiac output decreases. Whenever the cardiac output ultimately the BP will come down. That's one point. Second point, by blockade of facilitatory presynaptic beta 2 receptor. Whenever the beta 2 receptors are stimulated presynaptic, causes the increased release of neurotransmitters, adrenaline and noradrenaline, which has got it increases the blood. Is a positive inotropic action on the heart as well as blood pressures, the BP increases. So by blocking these presynaptic receptors, this decreases the release of neurotransmitters, adrenergic neurotransmitter, adrenaline and noradrenaline. That is second reason. One more, it blocks the beta 1 receptors located in juxtaglomerular cells of the kidney. We know stimulation of beta 1 receptors in the juxtaglomerular cells of the kidney causes the renin, release of renin. We know renin causes the production of angiotensin 2, which is a potent vasoconstrictor which increases BP. So by blocking this, it also contributes to antihypertensive effect. And by block, it also decreases the central sympathetic flow. By blocking the beta receptors located in the brain, so it also decreases central sympathetic flow. These are the mechanisms by which it reduces the BP. The four important mechanisms beta blockers reduce the blood pressure. So these are the classification we have discussed in previous classes. Nowadays, previous guidelines says that it is used as a first line drug or monotherapy as a first line drug. But recent guidelines says that it is not as a first line drug, cannot be used, can be used as a monotherapy, but not as a first line drug, because the efficacy of preventing it has got less efficacy in preventing the myocardial infarction and stroke. It does not have any effect in prevention of myocardial infarction and stroke. That is the reason we should not use beta blockers as the first line drug. So mainly preferred in young hypertension. Why young hypertension? The patient, like younger patient who develop hypertension, has been said that most of the studies say that the plasma renin activity is high in younger patient, younger hypertension. So that is the reason, since we know beta blockers blocks the renin release. So it is mainly beneficial in younger patient who are hypertensive. So that's why it's preferred in young hypertensive. Okay, can be used as monotherapy when AC inhibitors, ARBs are contraindicated. Whenever the patient has some contraindication for ACB inhibitors or ARBs, like pregnancy or any other contraindications, if the patient is not tolerable drug, in those conditions, it can be used as a monotherapy as well as first line drugs, but not general. So limitations, we know side effect because it blocks the beta 2 receptors on the lungs. They are contraindicated in bronchial asthma. So it blocks masks the warning sign of hypoglycemia. Cannot be used in diabetes. Diabetes, we cannot use the beta blockers. So because of worsening of peripheral vascular disease leads to gangrene, cannot be used. It impairs the exercise capacity. In order to overcome these side effects, we can use always prefers the cardioselective beta blockers, which is safely we can use in drugs like asthmatic diabetes, peripheral vascular disease, and it does not like impair the exercise capacity. To overcome the side effects of non-selective beta blockers, we can always go for cardioselective beta blockers. Thiazides. So, what are the thiazides used as antihypertensive medication? The three important drugs like hydrochlorothiazide, clothalidone, and indapamide. So, what is the antihypertensive mechanism? How it reduces the BP? We know thiazides acts by blocking the sodium chloride symporter in the early distal tubules of the nephron. So whenever you inhibit the sodium chloride transporters, there will be excretion of sodium and water takes place, natriuresis or diuretic effect. So excretion of sodium and water takes place. So whenever the excretion of sodium and water takes place, the plasma and extracellular fluid volume reduces. Okay, whenever the blood volume reduces, ultimately the cardiac output decreases. When cardiac output decreases, blood pressures will come down. Okay, and one important point you have to remember: this sodium. Okay, the concentration of sodium in the blood vessels that causes the stiffness of the blood vessels. Whenever the blood vessels are stiff, the peripheral resistance increases. That also contributes to the hypertension. So whenever you give, because of diuretics has got natriuretic effect, it causes the sodium loss. So it reduces the stiffness of the blood vessels. So that decreases the total peripheral resistance and leads to decreased blood pressure. Okay, one more, the thiazide data got vasodilatation is a lesser importance. It produces vasodilatation by opening ATP sensitive potassium channel, thereby hyperpolarization of the vascular smoothness, peripheral resistance decreases, BP decreases. Okay, this is of lesser importance, thus these are the two important mechanisms contribute to anti-hypertensive effect. So the important adverse effects we know, it produces hypokalemia, hyperlipidemia, impotence, diabetes, and gout. So whenever you use this drug at a dose of 50 milligram per day, as I said, these side effects are maximum. So that's why it is always advised to start the 12.5 milligram to the maximum of 25 milligram per day. Hydrochlorothiazide or these drugs should be started with the dose of 12.5 to 25 milligram per day, because when you start at this dose, the incidence of all these side effects will be less at this dose. Okay, although some textbook mentions the dose of thiazide 6.25 to 50 milligram, so some studies have shown that when you use at this dose 12.5 to 25 milligram per day, so the incidence side effect is less. Okay, so whenever the drug is not producing a reducing the BP at 25 milligram per day, it is advised to go for other drugs rather than increasing thiazide. It is advised always to go for the other group of drugs, because increasing more than 25 milligram does not produce any benefit. So it is preferable to go for the other group of drugs. So hydrochlorothiazide is the T off is about 24 hours. Okay, clothiazide is a thiazide like diuretics. It has got 48 hours. Okay, the incidence of side effect is less in clothiazide and indefinite compared to hydrochlorothiazide. Okay, nowadays is the first choice of monotherapy in the elderly hypertensive. Okay, ineffective in patients with chronic kidney disease, because they decreases the extracellular fluid volume, decreases the GFR. That's why should be contraindicated in patients with chronic kidney disease or renal failure. That's one point you have to know. Loop diuretics. Loop diuretics basically there's a weaker antihypertensive because they got short duration of action. So that's why we are not using this drug except in case of hypertensive in a crisis where there is a rapid reduction of blood pressure is required. So these drugs, by blocking the sodium potassium chloride co-transporters, decrease the plasma volume, decrease the cardiac output, as well as decrease BP comes down. Because of shorter duration of action, cannot be used as an antihypertensive, or it is a weak antihypertensive drug, can be used in the hypertension which is complicated by chronic renal failure and refractory congestive heart failure. That is the indication of the antihypertensive. The next group of drug is aldosterone receptor antagonist, that is the spironolactone. So we know this aldosterone, they causes increased excretion of epithelial sodium channels in the distal tubules, which causes reabsorption of sodium in exchange with potassium. So by blocking this aldosterone, there is no expression of these epithelial sodium channels. So there will be more of natriuresis, blood volume decreases, okay, cardiac output decreases, there will be slight reduction in BP. Okay, it prevents the potassium loss. So it is always combined with the thiazide diuretic, because thiazide produces hypokalemia, that is increased expression of calcium, potassium takes place in the thiazide. To prevent that, we add the spironolactone along with thiazide. It has got one important property that it inhibits the prolonged hypertension causes vascular and ventricular hypertrophy and renal fibrosis. So by reducing the BP, it has got beneficial effect or retards the vascular and ventricular hypertrophy and renal fibrosis. That's why I told it is used along with the ACE, ARBs, calcium channel blockers, and the thiazide. Okay, so it has to be carefully used in AC inhibitors. When you combine with AC ARBs inhibitors, AC inhibitors and ARBs, you have to check for potassium level, because hyperkalemia is also the side effect of AC inhibitors. So to carefully monitor the potassium levels when you're using the AC inhibitors or ARBs. So thiazides we can use because the thiazides have got side effect of hypokalemia, which can be neutralized by this spironolactone. ACE inhibitors, ARBs, and electron inhibitors. ACE inhibitors like captopril, lisinopril, perindopril. ARBs like sartan, losartan, candesartan, irbesartan. Direct renin inhibitors like aliskiren. These are the drug. So the mechanism action is almost same. Acts on the same path. ACE inhibitors we know inhibits the angiotensin converting enzyme. ARBs blocks the angiotensin receptors. Direct renin inhibitors block directly inhibits the renin. Ultimately, these drugs, what is the effect? Inhibits the angiotensin 2 mediated vasoconstriction. If it is not there, peripheral vascular resistance comes down, BP comes down. Okay, so in that angiotensin path, renin angiotensin pathway, aldosterone also will be inhibited. There is no sodium and water retention. When there is no sodium and water retention, the blood volume comes down. We know when blood volume comes down, cardiac output decreases, BP comes down. Okay, this is the anti-hypertensive mechanism of these AC inhibitors, ARBs or direct renin inhibitors. So contraindication, it has got teratogenic effects, so it should not be used in pregnancy. It is contraindicated in bilateral renal artery stenosis. Okay, status as antihypertensive because the long-term activity of renin-angiotensin system, which leads to vascular hypertrophy, ventricular hypertrophy, and increased mesangial cell growth in the kidney, leads to nephropathy. We have discussed that in the previous class in renin-angiotensin system. Since by inhibiting the renin-angiotensin pathway, so it retards or prevents the progression of left ventricular hypertrophy, inhibits the vascular hypertrophy, and inhibits the messenger cell growth. So it is beneficial in patient with congestive heart failure, a cardiovascular patient, or renal patient, diabetic nephropathy or nephropathy. So it is produces beneficial effect in those individuals. That is the hypertensive of choice in patient with cardiovascular disease and the renal disease. Okay, this is also first choice of drug in the younger patient. I told younger patient have got increased plasma renin activity, which is inhibited by the AC inhibitors by acting on the renin-angiotensin pathway. So prefer hypertensive in patients with diabetes, nephropathy, left ventricular hypertrophy, congestive heart failure, and post-myocardial infarction because of its beneficial cardiovascular and cardioprotective and renoprotective action of these drugs. So how to go about this? So we have learned this so much about the different class of drug, how to go about the treatment. So it is for the classified into patient with less than 55 and more than 55. Okay, if the patient do not have any compelling indication or any risk factors, the patient with less than 55 years of age, in the step one, we have to add the AC inhibitors or one drug. We have to use here in step one, we have to either choose from the AC inhibitors or ARBs. If the patient is having any cough or angioedema or not tolerant to AC inhibitors, we know ARBs will not produce cough or angioedema, so we can choose ARB. If the patient is not responding, either we can choose AC inhibitor or ARB, one drug you have to choose from each. If the BP is not coming down with one drug, we have to add the two drugs. Okay, preferably we have to add the calcium channel blockers or diuretic. You choose one from this group and one from this group. So there will be two drugs. In step 3, if still BP is not coming down, you choose add once let it be one drug from the ARB, calcium channel blockers you have to add, and thiazide. These are 3 drugs you have to add. Okay, calcium channel blocker and diuretic. When these not controlled by 3 drugs, we call it as resistant hypertension. In those group, you have to add the aldosterone receptor antagonist if the potassium is less than 4.5 millimoles per liter. Okay, or you have to add the higher dose of thiazide if the potassium is more than 4.5 millimoles per liter. Okay, you can add the beta blocker. Preferably, we can add the carvedilol or nebivolol because nebivolol has got nitric oxide reducing property, and carvedilol it has a cardioprotective effect. You have to choose the nebivolol or carvedilol in beta blocker, and we can go for alpha blockers. Okay, along with these 3 drugs, we have to add the aldosterone receptor antagonist, spironolactone, or any thiazide. Because the higher dose of thiazide, you can add the beta blockers or the alpha blockers. That is in patient with less than 55 years of age. Only one change here is in the less than 55-year age group, we are starting with the AC inhibitors or ARBs. More than 55 years, you have to start with the calcium channel blockers or diuretics. Because I have told in the younger patient, Okay, that is age less than 55. They say that the plasma renin activity is more in this age group. Okay, here in more than 55, the plasma renin activity is less. So it is preferred to start with the calcium channel blockers or diuretic above 55 years of age, less than 55 years of age because of the plasma renin activity is high. Go for AC inhibitors or ARBs. Okay, if they are not coming down, you have to add ARBs here in the more than 55 age group. Okay, the same thing follows just like this group. So do drugs combination, three drug combination is not producing beneficial effect in three drug. Go for addition of another drug. We call it as the resistant hypertension. So what are the compelling indications? Whenever the patient has certain risk factors like heart failure, coronary artery disease, and stroke, choose the diuretics. Okay, AC inhibitors are preferred. Patient with heart failure, myocardial infarction, diabetes, renal disease because got cardioprotective, renal protective effect, hypertension, plus all these compelling indication. Choose these drugs. AC inhibitors or ARBs. Calcium channel blockers safer in diabetics, stroke, angina. Okay, patient with hypertension plus diabetes, stroke, angina. Choose the calcium channel blockers. Beta blockers can be selected patient with hypertension with stable compensated heart failure, post myocardial infarction, high risk of coronary artery disease. Okay, so if the patient don't have any of these compelling indication, follow this approach. If the patient is having compelling indication, you have to choose depending upon the which drug produces a beneficial effect in that particular disease condition. So that is how you should choose the antihypertensive drugs. So what are the drugs safer in pregnancy? Okay, so if the chronic hypertension, the lady is chronic hypertension, if she become pregnant, you just continue with the step care approach. Usually, the pregnancy itself induces hypertension at 20 weeks of gestation. Around 20 weeks of gestation, there will be hypertension due to pregnancy without pregnancy-induced hypertension, or otherwise called as preeclampsia. So, what are the drugs safer in this preeclampsia or pregnancy-induced hypertension? The first most commonly used drugs for the preeclampsia or the pregnancy-induced hypertension is methyl. The second group of drugs safer is labetalol. The third group is nitramycin, and the calcium channel dihydropyridines like nifedipine. The sustained release tablets of nifedipine is used. Okay, these are the you have to memorize. So they will be asked what are the drugs safer in pregnancy. If the drug BP is not controlled with these drugs, we can choose the cardioselective beta blocker also, except atenolol. Cardioselective beta blockers also we can choose. We can also go for Rexosin alpha blocker. We can also go for clonidine. Along with these two other drugs, if these are the safest drug, the BP is not coming down with this, we can go for cardioselective beta blockers. Other than we have to skip the atenolol. Other cardio blockers can be used with careful monitoring, and the alpha blockers like Rexosin and clonidine. These are the other drugs safer in pregnancy. These are the safest. These are the safest drugs that can be used in pregnancy. So what are the drugs to be avoided in pregnancy? AC inhibitors, ARBs, we know it produces teratogenic, causes fetal damage and growth retardation. Diuretics, because we know it reduces the blood volume, decreases the uteroplacental perfusion will be reduced. That leads to miscarriage and stillbirth. Non-selective beta blockers, propranolol, okay, causes low birth weight, decreased placenta size, neonatal bradycardia. Sodium isopropyl because it produces cyanide that produces cyanide toxicity in both mother and the fetus, so it is contraindicated. So the group AC inhibitors, ARBs, they direct resources we can add here, diuretics, non-selective beta blockers like propranolol, sodium nitroprusside. These are the drugs absolutely contraindicated in pregnancy. Hypertensive emergency. So hypertensive emergencies condition will be the BP will be, these are the hypertensive crisis. So there will be two definitions. One is hypertensive emergencies, other hypertensive urgencies. Hypertensive emergencies, systole more than 220, diastole more than 150. With target organ damage, we call it as hypertensive emergencies. Without target organ damage, we call it as urgency. Okay, otherwise any blood pressure above 180 is considered as hypertensive crisis. So what are the hypertensive emergencies like cerebrovascular accident, head injury, okay, left ventricle hypertrophy, pulmonary edema, hypertension. In all these angina, acute renal failure, eclampsia, fake chromocytoma, in this all these conditions there will be Systole will be more than 180 milliliter of mercury. So what are the drugs used in hypertensive emergency? So a table from the Harrison. So drugs like nitroprusside. So preferably we are to give, because it's an emergency condition, we have to give all drugs intravenously. The goal of the therapy is to reduce the BP to 25% in first hour. Okay, in this next 2 to 6 hours, should not be less than 160 by 100. Should not go below 160 by 100 in the next 2 to 6 hours. So careful reduction of BP should be done. Okay, we should not suddenly, because if it goes below 160 to 100, the perfusion of vital organs like cerebral blood vessels, kidney, and the heart suffers. There will be angina, precipitation of angina, renal failure. There will be cerebral vasospasms. That's why it should not, in the next 2 to 6 hours, the BP should not be below 160 by 100. So gradually, careful monitoring of reduction of BP is recommended in this condition. Let us like to memorize the drugs: nitroprusside, nicardipine, labetalol, enalaprilat, not the enalapril, it's the enalaprilat, esmolol, ultra short acting beta blocker, pentylamine, nitroglycerin, hydroxyl. So these are the drugs used in the emergency hypertensive emergencies. Okay, very important. Okay, one more important point I forgot to tell here is what is the target blood pressure? It should be less than 140 systolic and the less than 90 diastolic in patient less than 55 years. Okay, less than 55 years. This is the target reduction of BP. Okay, with or without kidney disease or diabetes. In patient more than 55 years or more than 60 years, the target reduction should be less than 150 systolic, less than 90 diastolic in patient with more than 60 years of age. Okay, in patient with more than 60 years of age with diabetes and other morbidity, chronic kidney disease, the systolic is 140, diastolic is less than 190. Okay, this is the target goal we have to keep it in mind while starting the hypertensive drugs. So any participants are there? We start some, solve some MCQs. Okay, we'll see, this is a MCQs. Which of the following drugs should not be used in pregnant women with hypertension? So they're asking what are the drugs are teratogenic in this? Okay, we know ACE inhibitors, ARBs, beta blockers like propranolol, they're contraindicated in pregnancy. So among the following options, the labetalol is the safest drug in pregnancy, methyl dopa, hydrolysis, these are the safe drug in pregnancy. The only option is propranolol is contraindicated in pregnancy. The answer is propranolol. Nitric oxide acts by, we have learned that nitric oxide stimulates the Golan cyclase activity, which increases the cyclic GMP, okay, which causes dephosphorylation of myosin light chain kinase, and also inhibits the calcium entry, causes relaxation of blood vessels, and BP will come. So mainly it acts by increasing the cyclic GMP. Which of the following is not a centrally acting antihypertensive drug? Among the following drugs which is not acting centrally, okay, we know methyl dopa acts in the central nervous system in the brain. Okay, clonidine, we know it's an alpha 2 receptor agonist. Moxonidine also, it is an alpha 2 agonist. Minoxidil acts in the periphery on the blood vessels by opening the ATP sensitive potassium channel. Okay, so this is not a centrally acting antihypertensive. Answer is minoxidil. Drug of choice for hypertension in pregnancy. The following option, what is the drug of choice for hypertension in pregnancy? Okay, so don't go for directly magnesium sulfate because they're asking hypertension in pregnancy. Our aim is to reduce the BP in eclampsia. Magnesium sulfate is used to control the convulsions. Eclampsia means what? So whenever the pre-eclampsia patient, that is pregnancy-induced hypertension, when they develop the convulsion or seizures and CNS manifestations, we have to go for magnesium sulfate to control the convulsions, not to reduce the BP. So here they are asking the drug of choice for hypertension in eclampsia. So the drug is labetalol. Which of the following statement is true about clonidine? Sudden withdrawal will lead to BP. Yeah, that is true. Correct. Plasma half-life of clonidine is 8 to 12 hours. That is correct. It acts through activation of alpha-2 receptors in the brain cell. That is also correct. Okay. It does not cause postural hypertension. No, it causes little bit of postural hypertension, but it's not problematic. It is asymptomatic. Which of the following drug is contraindicated bilateral renal artery stenosis? We all know ACE inhibitors or ARBs are contraindicated. So among the given option, the drug is enalapril is a ACE inhibitor. Which of the following antihypertensive is not given in pregnancy? Safe for drug in pregnancy, they are asking. So we know these drugs can be given in pregnancy, safe for drug in pregnancy. ACE inhibitors like enalapril are contraindicated. So answer is enalapril. All of the following can be administered in acute hypertension during labor, except nothing but pregnancy-induced hypertension. So the nitroprusside it causes release the cyanide ions, which is toxic to both mother and the baby. So we should avoid IV nitroprusside. Other drugs can be safely IV, not the nitroprusside. Option is IV nitroprusside. Systemic vascular resistance is twice that of normal. Treatment should be there is increased peripheral vascular resistance. So you have to choose the drug with decreased peripheral vascular resistance. So adrenaline, noradrenaline, and isopressin, these are the vasopressor drugs, which increase the blood pressure by increasing total peripheral resistance. Okay, among the given options, sodium nitroprusside is the one which dilates both the arteries and vein, decreases the total peripheral resistance, thereby decreasing the BP. So we want to reduce the systemic vascular resistance. Okay, the treatment should be sodium nitroprusside. Which of the following drug reduces the BP primarily by directly decreasing the heart rate alone? So we know only the beta blockers, correct? Beta blockers are acting on the beta 1 receptors on the heart, decrease the cardiac contractility, decrease the heart rate, decrease the cardiac output, and BP will come down. So among the following options, the propranolol is the one which acts by blocking the beta 1 receptor of the heart, so thereby reduces the pressure. Okay, although it is not cardioselective, it can act on the beta 2 receptor also, but among the given option, prazosin, we know it's alpha 1 selective blocker. Alpha methyl dopa is the centrally acting drug which inhibits the sympathetic flow. Sodium nitroprusside is an arterial and we know dilator by reducing the nitric acid. So it's a non-selective drug mainly acts on the beta by inhibiting the beta 1 receptors, decreases the blood pressure. So among the following option, the answer is option. Which of the following statements about diazoxide is false? We know diazoxide is an arterial dilator. So it acts by opening of ATP-dependent potassium channel, thereby decreasing the blood pressure. So it also causes the opening of ATP-sensitive potassium channel in the beta cells, decreases the insulin release. So it can be used in the treatment of insulinoma. So this is the correct statement. This is the correct statement. Okay, it is used as antihypertensive. Correct statement. Okay, we have learned that diazide produces two important side effects. One is hyperglycemia, other is hyperuricemia. Okay, so it does not produce hyperglycemia. So this is the wrong statement. Alpha methyl dopa is primarily used for pregnancy-induced hypertension. Okay, safer drug in pregnancy. Straight answer. All of the following statement about clonidine are true. It is an alpha-adrenergic agent. Yeah, we know it acts on the alpha-2 receptors. This is the correct statement. It can cause dry mouth as an adverse effect. Yes, it produces dry mouth, xerostomia, dry eyes. Correct. Prazosin completely completely antagonizes its action. That will come to that. It inhibits the sympathetic flow. Yeah, by stimulating the alpha-2 receptors in the central nervous system, it decreases the central sympathetic outflow. So remember, its action is on the central nervous system, CNS. Prazosin is what? It is a peripherally alpha-1 receptor blocker, alpha-1 blocker, which acts in the periphery. So when our action of clonidine is in the central nervous system, how can prazosin antagonize the action of clonidine? So this is the wrong statement. So it cannot antagonize the action of clonidine because the action of clonidine is on the central nervous system, not on the periphery. So prazosin completely not antagonize the action. Here. All of the following are useful in the intravenous therapy of hypertensive emergencies, except So these are the drugs can be given. Okay, enalapril we have shown we have learned in that table. You have to remember the table. Irapital is an alpha blocker. This is the ACE inhibitors. We know enalaprilat. Okay, phenylidopam is a dopamine D receptor agonist. So these are drugs are used. Nifedipine, if it is used, it should be given sublingual. Okay, in hypertension emergency, they ask intravenous therapy for hypertension emergency. Nifedipine cannot be used intravenously. If you use nifedipine intravenously, so there will be sudden fall in BP, there will be reflex tachycardia, there will be worsening of unstable angina. So it is contraindicated. So if at all you want to give nifedipine, it should be given sublingually, not be intravenous. First of all, it should not use intravenously because give intravenously sudden fall in blood pressure because it's short acting, worsening of angina, unstable angina. So it should be avoided. If at all you want to give, you can give sublingually sustained release formulation can be. So the answer is nifedipine. A 50-year-old patient with malignant hypertension or hypertension faces the drug of choice is this sodium nitrochloride always, not the enalapril. We have to give enalaprilat, not the enalapril. Maximum incidence of impotence is seen with the following antihypertensive drugs. So remember the antihypertensive drugs are known to cause the sexual dysfunction in males. The rank order is thiazides. Thiazides is the one which produces maximum sexual distress, dysfunction or libido, followed by beta blockers. Okay, whereas calcium channel blockers safe, does not produce any. Okay, the ACE inhibitors also safe. Yeah, this does not produce sexual dysfunction. So if you remember the rank order, if thiazides is there in one of the options, you have to go for thiazide. That is the high risk in sexual dysfunction is seen in thiazides. Next is beta blockers. So among the given options, calcium channel blockers, ACE inhibitors are safe. It does not produce sexual dysfunction. So the beta blockers. Which of the following about hydrolysis is not true? It causes direct relaxation of blood vessels. Yeah, it is an arterial dilator for our statement. Dilatation both arteries and veins. No, it is a preferably more dilates only arteries, no effect on the vein. Postural hypertension is not a common problem. Yes, because no action on the veins. We know any drugs which causes venodilatation that produces potential postural hypertension is more common in those drugs which produces venodilatation. It increases the plasma adrenaline activity. Obviously, any drug which decreases the blood pressures by dilating the arteries has got compensatory reflex increasing plasma renin activity. That's why these drugs has to be combined with beta blockers. Okay, so among the given option, these are the true. So they are saying it acts both on the arteries and veins. No. Okay, if they are preservation acts on both arteries and veins, not the arterial dilators like item. The name itself is arterial dilators, so it acts on the arteries, not on the veins. The following statement is not true about the use of clonidine in the treatment of hypertension. It reduces the central sympathetic outflow, that is the correct statement. Increase LDL and unflowing used. No. So they decrease the LDL, increase the HDL. It has a favorable plasma lipid profile. Sedation, xerostomia are common side effect. That is the right statement. It is combined with vasodilators. I told vasodilators, whenever you give this drug, there will be reflex tachycardia because of the compensatory increase in sympathetic nervous system activity, reflex tachycardia. When you give clonidine, this reflex tachycardia can be blocked by clonidine. That is the combination is rational. So this is the right statement. Here the wrong statement is it increases the LDL cholesterol. Usually it decreases the LDL cholesterol, increases the LDL. It has got favorable plasma lipid profile. So a 90-year-old hypertensive patient on antihypertensive receptors, Losartan, is posted for hernia surgery. The antihypertensive drug should be continued till the day of operation, stop 24 hours before surgery, stop 1 week before surgery, administer the increased dose in the day of operation. So whenever these drugs are there, antihypertensive drugs should be continued till the day of operation. This is the criteria. You have to continue it till the day of operation. This especially antihypertensive drugs has to be continued till the day of operation. That's the answer. So an elderly hypertensive has diabetes inhibitors, bilateral renal is the best management. Among the following option, which is the best? Of course, AC inhibitors or ARBs are beneficial in diabetes, but contraindicated in bilateral renal artery stenosis. Okay, so among the following drugs, so the beta blockers increase the risk of the massive warning sign of hyperglycemia, so cannot be used in diabetes. On a long-term basis, beta blockers also decrease the insulin release, which causes diabetic-like state. So we cannot use beta blockers. Okay, so the safer drug among this is calcium channel blockers. Can use the calcium channel blockers. Okay, that is the drug answer is verapamil. Antihypertensive drugs beneficial are having neutral load in the lipid profile. But remember, this is also one of the most commonly asked questions. So, which drug has got favorable lipid profile? Prazosin and clonidine got favorable lipid profile. That means it increases LDL, HDL, decreases the LDL. Okay. Calcium channel blockers, ARBs, AC inhibitors, no action, no effect on the plasma lipid profile. Beta blockers, diuretics, decreases or they have got unfavorable lipid profile, or these drugs increases the LDL, decreases the HDL. Okay. Favorable lipid profile seen with prazosin and clonidine. Okay. Unfavorable lipid profile seen with beta blockers and diuretics. CCBs and ARBs, ACEI, no effect on the plasma lipid profile. So they are asking which drugs are having beneficial or no role in lipid profile. So among the following action, so prazosin is a produces beneficial effect. Losartan has got neutral effect on the lipid profile. So beta block propranolol is a beta blocker. These are thiazide diuretics. So this is loop diuretics. This thiazide diuretics they got dyslipidemia. They increases LDL and decreases the HDL. So the option is prazosin and losartan. Combination of beta blockers and calcium channel blockers count. That's why I told in the beginning of the class, we better avoid beta blockers with calcium channel blockers like verapamil and diltiazem, because there will be additive sinus depression, bradycardia, heart block. So what if you combine, what happens? There is heart block, hypertension, bradycardia. It has got negative inotropic action on the heart. Both beta blockers and calcium channel blockers has got negative inotropic action on the heart, produces all these effect, not hypertension or bradycardia. Okay, so the references. That's all for today's class. Hope you have understood something. So if you have any doubts, any questions, any queries, you can always mail to me. This is my email ID. Thank you for listening to me. Thank you. Any doubts?